So I had to come up with the title. First of all, thank you very much to the organizers for inviting me. I'm not sure that what I'll be talking about is all that innovative, but hopefully relevant to the topic. The title I came up with seems to work the best is Linking State, Community, and Intervention Factors with Population Changes in the SPIF-SIG cross-site evaluation. The SPIF-SIG, for those of you who are not familiar, was a SAMHSA initiative. It's still ongoing. Our evaluation covered the first two cohorts, and it stands for Strategic Prevention Framework State Incentives Grant. The goals, briefly, of this initiative, which is rather large, are the kind of standard goals that you look for in substance abuse prevention programs, mainly to prevent the onset and reduce the progression of substance abuse, reduce substance abuse-related problems and consequences such as alcohol-related motor vehicle incidents, things of that sort. And finally, to build prevention capacity and infrastructure to continue doing prevention at both the state and local level. And the way this was organized was that CSAP, which is the prevention branch of SAMHSA, essentially funded the states to implement this model. So that's where the programmatic dollars came from, and partnered with NIDA to fund a national evaluation of SPIF-SIG through an interagency agreement. And that's where we came in. And this partnership was really extremely important and vital to making this thing work. As far as how that, in so many ways in which those of you, I think, who work for government or have worked, done work sponsored by governments are probably well aware. NIDA wasn't responsible, of course, for the population data, but they were very much helpful in many, many ways for enabling us to keep the study on track so we could get the most use out of it. The SPIF model, just real briefly, it's generally described as having 5 steps. It's cynically described as they are neither 5 nor steps. Discuss. But in any way, descriptively, they are. It begins with assessment, and these steps go on at both the state and the local level. Assessment of needs, assessment of assets, essentially assessing the data and using data to assess the needs of the states and community. The second one being capacity building, both how to build capacity and how to use the capacity that's there and increase it. The third one being strategic planning, and this is a very specific type of strategic planning that is data-driven. I'll talk a little bit more about that as we go through this. And then using all that information from the strategic plan that brings together the assessment and the capacity of the state and communities to proceed, the actual implementation, which consists of funding communities to implement the program, as well as carrying out those interventions themselves at the local level. And then finally, evaluation, which is supposed to happen throughout the process, which really makes this a circle as opposed to a set of linear steps, because the way it's supposed to work, and the way it often does work, is that the evaluation is iterative, and the evaluation results in additional assessment capacity, so the circle remains unbroken. And then sustainability and cultural competence are in the center because they are supposed to weave their way through all of the steps. The ways in which this particular initiative differed from prior federal prevention efforts, I think, is relevant to the panel theme here, because one was the required use of epidemiological data to set state priorities and justify resource allocation to communities, which is generally called data-driven planning. Now, this all started back in 2004. And at that time, it was actually it really had not been done, at least on any large scale, in substance abuse prevention. It had been done a fair amount in public health, which is where a lot of these concepts and theories were derived from, but it was pretty novel in terms of a way to do business in prevention. And the second, and related to that, was reliance on population-based outcomes, because you can pretty easily see the connection between data-driven planning, which was also largely based on population data, as far as what are the needs, what are the hotspots, how do we compare to other states, how do we compare to other communities, but also outcomes to essentially do the evaluation, estimate the initiative's effectiveness. More traditional prevention programs had been more at the program level, which you can describe or even caricature in some cases. I mean, yes, we know how to provide interventions to 10th graders so that 30 days later they are more anti-drug. You know, the degree to which that's going to predict actual population change is obviously, you know, very, very thin. So this was also a big change. As far as who participated, I'm sorry, that's a mistake. It's actually 24 states and 2 territories, which in turn funded 450 communities, which in turn initiated 2,534 interventions. So it's a big initiative, and there's data on all of it. The research questions which relied on population data are really your standard cross-site outcome evaluation type questions. Basically, did this work, and what accounted for variation in outcome performance across, because you know that the did its work question is going to have a, I mean, before you even begin, it's going to have an it depends answer. So what actually did account for the variations in outcomes? And I'm going to touch a little bit on both those findings and hopefully the implications. Just in the interest of time, I'll skip over the criteria. But the view from 30,000 feet, I'm just going to, again, brush quickly on these tables. If you looked at the summary of community-level outcomes pre-post, and these were longitudinal measures using, again, population-based data such as the YRBS, such as the BRFS, you know, largely dependent on what the states and communities had available and provided. Take 30-day alcohol use, which was an important one because underage drinking was a big target. Of the number of states, I'm sorry, the communities, of 174 who targeted that priority, 132 showed improvement. If you look at the significance tests, 79 were significantly better, only 15 were significantly worse. And if you look at the other outcomes or priorities, as they were called, because they were what was targeted by the states on the basis of their strategic planning, the results are pretty similar. I mean, generally, it's all very positive. If you aggregate those community-level findings up to the state level, because it was, after all, really the states who were the main implementers and, you know, not only decided what communities were to be funded, but gave them guidance as to what to do, it's even actually more impressive. If you look at 30-day alcohol use of the 16 states that targeted, 14 showed improvement over time. If you look at the significance tests, 11 versus 1. And if you go down the list for the various outcomes, you pretty much see the same thing. Now, it is, of course, the case that these are just pre-post, and it was a period. This outcome period really from, say, around 2006 to 2012 was a period nationally of secular trend downward in substance abuse among these populations. So, so some kind of basis of comparison really is necessary. Again, because this was a naturalistic study in that states could fund comparison communities, or rather provide data on comparison communities, but didn't necessarily. So some did, some didn't. Ditto, some actually did randomize communities to one condition or the other. You know, most did not, but that was entirely up to the states. We had really nothing to do with it. But where, in fact, there were comparative data, actually, as it turned out, 30-day alcohol use was probably less impressive than the other outcomes. Why, we're not entirely sure. But binge drinking, 3 out of 4. Binge drinking among young adults, 1 out of 1. Drinking after driving, 3 out of 3, et cetera, et cetera. So essentially, even when the secular trend was taken into account, the results were generally, quite impressive over a large scale. So, and we also, where the states were what we call high coverage states, which is to say that their funds were able to cover more than 50% of the population of the state. We also looked at how the state needle moved relative to the national trends. And in fact, in 30-day alcohol use, 7 states qualified, 5 improved relative to the U.S., ditto for binge drinking. So you can see at that level as well, the results did appear favorable. So obviously that's very much the view from 30,000 feet. There's a lot more details involved, and you're welcome to question the methodology, but I know today's not the day for that. But overall, the findings were quite impressive. So summarized, favorable community level pre-post changes were observed. Many cases also observed in comparison communities, but even so, about 2/3 of targeting communities, and again, that was the 450 across the country, did improve relative to their comparison communities. And a similar finding was observed for high coverage states relative to the U.S. as a whole. So, good news. The second big question is, what does explain success? And I guess this is where things get sort of interesting here, because now we're talking about, not just, yes, we have an evaluation using population data, which was a big deal at this scale in prevention, but also we have all of these predictors at the state, community, and intervention level that were also collected to see if we could explain it. Among the community level predictors, we looked at funding and organizational support, coalition capacity, the step scores. We had a number data there in terms of implementation fidelity, as well as intervention variables. At the state level, it really wasn't all that predictive. I would say in general it was somewhat disappointing, although this is not to say that the state factors in terms of infrastructure development and infrastructure growth were not important. In many cases it might have been because there was simply less variability, but for whatever the reason, that really wasn't where the action was, although some people predicted that it might be. The communities were really where the action was. In terms of funding and organizational support, it's something of a mantra that, particularly for sustainability, that leveraging funding, getting more funding, using the federal grant to, go to foundations, to go to other places and, use the data to get more, will in fact be a good thing. But we actually showed it empirically, which was not trivial, that communities that received additional prevention dollars beyond their SBF funding were more likely to achieve significant reductions on their targeted population outcomes. There was some variation on funding source. For example, it appeared that the block grant funds and community or municipal funds did predict significant favorable outcome changes, whereas other sources like foundations, corporate dollars, private contributions had little or no observable effect. The exact reasons for that we haven't really delved into, but it was in observations. And for the most part, organizational support variables didn't have a lot of, for example, the degree to which the state provided a lot of technical assistance to the communities. Now again, it wasn't because the states didn't provide technical assistance or because that the technical assistance wasn't valuable. In many cases it was because there wasn't that much variation. They all provided technical assistance, and for the most part 98% of the communities were satisfied with that. So it may not mean that much, that it didn't explain much, but nonetheless that's what we found in terms of funding and organizational support. Coalition capacity. If you're into prevention, then of course you know about coalitions, and there's much controversy about how important they are. We actually did find that among community partners who self-identified as coalitions, and that was about 2/3 of them, higher scores on coalition attributes did in fact predict significantly greater reductions in one or more underage drinking outcomes. And that was generally across the board. A summary coalition capacity score constructed from all of the individual items in an assessment tool that my colleague Bob Flewelling at Pyre came up with, in fact did show results that at least the coalition advocates were quite happy with. And in terms of intervention variables, this was also quite interesting. A big part of this initiative, which I didn't talk about, was what kind of strategies, what kind of prevention strategies are actually going to affect population change, because clearly moving the needle at the community level versus the state level, is going to require something that in fact has the reach to affect a lot of the population. So There was a big emphasis on what became known as environmental strategies as opposed to the traditional prevention programming. So environmental strategies, for those of you who are not familiar, at least in prevention, are things like, there's large-scale education campaigns, things at the community level, particularly with alcohol, like changing zoning laws, making density of liquor stores, making things like beverage server training, keg parties, sponsoring alcohol-free events. There's all kinds of things that are considered environmental that, as opposed to individual level, that were really pushed on in this evaluation in order to specifically affect population change. And sure enough, we did find that the number or percentage of strategies that a community implemented that were environmental did predict significantly greater reduction in outcomes. And that was also true. There are several domains. I can kind of describe what the domains are, but if in fact it was on the more society environmental domain as opposed to, say, an individual or a school domain, in fact that also predicted favorable change. I'm not sure how to read this. How am I doing?
You're out of time.
Oh, I'm out of time. I'm sorry. Okay. So
take a minute or two to wrap up.
I'll take a minute or two to wrap up. So just very briefly on adaptation, which is also, of course, a big issue in implementation science. We looked a lot at that, and what we found was that the modifications to the traditional things that you find in prevention programming, like dosage, duration, and setting, really did not appear to have a big effect. And yet adaptations to better meet the needs of the target population, which SAMHSA has generally referred to as cultural competence, which has been advocated, did in fact predict a favorable change. And this is a big deal if you've been advocating for the importance of cultural competence for a couple of decades now, but haven't really had any empirical support from population data that show that it mattered. Here actually is some. So I think the implications for the conference theme are to do this more in terms of do evaluations with population data, do it better. I can easily go through the various constraints on our study, explain it simply, because clearly, I guess I'm a big proponent of dumbing it down, not to be inaccurate, but just to make sure that people who aren't very patient listening to caveats are able to grasp it quickly. And a theme that I suspect will be heard throughout the day and tomorrow having to do with protecting and expanding the data systems that make it possible, because it really was a big obstacle. I can tell you some of the horror stories about budget cuts post-recession that in fact killed student surveys, that actually knocked entire states out of this evaluation. But they're probably the types of stories you've heard before. So that's it. Thank you very much.